Reports Meet the Author webinar. My name is Frederick Shaw, and I'm the acting editor of the journal Public Health Reports. It's the official journal of the U.S. Public Health Service and the Office of the Surgeon General. The journal is published by ASPPH, the Association of Schools and Programs of Public Health. This webinar series is presented by Public Health Reports and ASPPH to stimulate discussion around current topics in public health. Today's webinar is entitled A New Strategy for Public Health Surveillance at CDC, Improving National Surveillance Activities and Outcomes. It features three top experts in surveillance strategy, and they're going to discuss CDC's new surveillance strategy and how surveillance data are crucially important to inform policy changes, to guide new program interventions, to sharpen public communications, and to help agencies assess their research investments. This webinar is based in part on a feature article in the November-December issue of Public Health Reports, written by Dr. Chesley Richards, who's our lead presenter today, and by Dr. Michael Yadamarco and Dr. Tara Anderson. In a moment, I'll turn the webinar over to Dr. Richards to provide an overview of the new CDC surveillance strategy, but first, a couple of quick housekeeping issues. First, I want to let you know that this webinar will be archived on the Public Health Reports website for future viewing. That's www.publichealthreports.org. And second, there will be a question and answer session following these presentations. So if you want to submit a question for the Q&A session, type your question into the chat question box, which you can open by clicking the small white arrows that are in the upper right-hand corner of your screen. And don't worry, if your question is not answered during the presentation, it will be included in a Q&A posting on the Public Health Reports website, along with the presentations themselves. So now it's my pleasure to introduce our first speaker, Dr. Chesley Richards, who's Director of the Office of Public Health Scientific Services here at CDC. Dr. Richards.
Thank you, Dr. Shaw, and thank you for the opportunity to talk to all of you about CDC surveillance strategy, and thank you for joining this webinar. Next slide. As many of you know, the world of health information is transitioning. Next slide. From slower, labor-intensive organism identification to rapid, automated whole genome characterization. Next slide. We're changing from a focus exclusively on individual health care to population health management. Next slide. We're moving from a world of exclusively professional interpretation of data to really inform consumers. Next slide. We're moving from individual small data to distributed big data analytics. Next slide. On the front lines in public health, we're moving from periodic organized news updates to almost instant access to raw information. Next slide. CDC, as outlined by our director, Dr. Tom Frieden, has three general areas of strategic direction. One is to improve health security, both here in the U.S. and around the world. The second is to address really the leading causes of death, of illness, injury, disability. And finally, to further our integration and collaboration between public health and healthcare sectors. Next slide. In public health, there are 10 essential functions that local, state, and national public health agencies need to fulfill, and high-quality, timely, actionable data is crucial to all of these functions. Next slide. The vision underlying the CDC's new surveillance strategy is really to create efficient systems that put the right data and information in the right hands at the right time, in the right format to take effective public health action. Next slide. And when you look at the domains that need to be addressed in order to meet this vision, they're really domains of efficiency, quality, access to data, timeliness, and the ability to analyze data, and creating data and knowledge and information that is really actionable and supports decisions. Next slide. With a charge from our director and with a process that included input both inside CDC and outside of CDC, we devised a strategy focused on addressing 4 key issues: improving the availability and timeliness of surveillance data to both CDC programs and our state, tribal, local, and territorial partners; to advance the effective use of emerging information technology, including electronic health records, mobile technologies, and cloud computing; to identify and amend or retire ineffective or unnecessarily redundant systems; and to overall maximize the effectiveness of our available agency public health resources devoted to surveillance and the performance and coordination of our surveillance systems. Next slide. What are the challenges? CDC operates, supports, or participates in over 120 surveillance systems or activities. Many of these systems are siloed, and they often function well, but at a cost. The cost are the interconnections, the interdependencies, and the efficiencies that are not realized. And for local and state health departments, these plethora of systems have burden and requirements that are increasingly difficult to meet. Technology, in terms of technology, we have been relatively slow to adopt the new technologies that offer us new avenues for both obtaining and analyzing data. And in many places, we have insufficient workforce with the right skills and the right to do the kind of work we need for surveillance. Finally, there are challenges in addressing emerging health information policy related to the fast-moving areas of electronic health records and meaningful use standards and interoperability requirements. Next slide. Next slide. What are the opportunities? Well, we can move increasingly from manual reporting from traditional data sources to more automated data use and analyses from novel sources, including the electronic health record and healthcare data systems. We can improve the interoperability among jurisdictions in various types of data systems. We can institute more novel partnerships and collaborations to overcome limited public health informatics resources. And we really are on the verge of a revolution in analytics and visualization and communication about public health data and information. Next slide. In our strategy, we've identified 4 areas to focus on for the next 18 to 24 months that are really priority areas for improving national surveillance. The first, and you'll hear more about this by Dr. Hume, modernizing our national notifiable diseases surveillance system is a priority, a system with over 80 conditions reported. And in improving this system, we can move into a new world for notifiable disease reporting. Enhancing our biosense application on syndromic surveillance, accelerating our electronic laboratory reporting efforts with our state and local health departments, and accelerating electronic death record use, working with state vital statistics programs and the National Center for Health Statistics. Next slide. In terms of modernizing our national notifiable disease surveillance system, the efforts we're undertaking are assuring that we'll get to the point of having a common language using HL7 language for our reports to CDC. We're developing a state-of-the-art platform which will improve data exchange services. And we're providing technical assistance to states supporting program implementation. Next slide. In terms of improving national syndromic surveillance, we're working to improve data access, quality, and representativeness along with timeliness. We're enhancing the capabilities and technology supporting syndromic surveillance data collection, processing, and provisioning. and strengthening the National Syndromic Surveillance Community of Practice to promote data sharing and further the science and practice of syndromic surveillance. Next slide. For electronic laboratory reporting, we're enabling jurisdictions to implement and support standards-based electronic data exchanges, thereby increasing the number of laboratories sending reports to public health electronically. We're improving the processing of our electronic laboratory reports and their ability to be used by our health departments, and collaborating with laboratories and their laboratory information management systems, LIMS, the vendors, to improve ELR content quality and completeness. Next slide. Finally, in moving to electronic death reporting, we're improving the timeliness, creating a state-based network of enhanced electronic death registration systems, improving physician participation in that electronic system, improving the quality of cause of death information on death certificates, transmitting deaths of interest and concern to state public health to the state epidemiologists within 1 day of registration, and reporting deaths to NCHS, 80% of all deaths, within 10 days of the date of death. This is our performance goal to reach in the next 18 months. Next slide. If you look at the continuum of how data flows, is used both at its sources by local and state health departments and ultimately comes to CDC through some of the systems I've described. Our initiatives focus on different aspects of that continuum. So electronic laboratory reporting, electronic death registration or reporting, and syndromic surveillance are really about improving the data flows from the sources to the health departments. And the National Notifiable Disease modernization effort is about improving data that's coming to health departments and going to CDC. And along this continuum, we're providing technical assistance in both areas. Next slide. Finally, to complement the initiatives we've undertaken, we also have a number of areas where we're focusing on informatics innovation. These are just 3 examples of some of the work we've been doing. First, we're developing an integrated surveillance portal, also known as Project Apollo, that will give us a dynamic tool to understand the relationships between the 120 to 180 surveillance activities or programs or systems that we have. Second, we've created a Surveillance Strategy Innovation Project Award program that we awarded 9 small projects within CDC to advance informatics innovation in the last year. And finally, we are engaging surveillance vendors through a vendors forum to increase the dialogue between public health and the vendors who supply the products we have. Next slide. So thank you for allowing me to give you this overview of our surveillance strategy. And here we have further contact information if you'd like to have more information about the program. Now I have, next slide. Now I have the distinct honor to introduce Dr. Perry Smith, formerly the Director of the Division of Epidemiologists and State Epidemiologists in New York, and currently a research professor at the State University of New York at Albany. Dr. Smith, thank you.
Yes, thank you, Dr. Richards, and thank you and the organizers of this webinar for inviting me to be able to talk a bit about state and local perspectives on the surveillance strategy. Next slide. What I'd like to do in the next few minutes is to go back and visit a little bit of background information on the National Notifiable Diseases Surveillance System, particularly as it affects state and local health departments, and then cite 2 types of input into perspectives that have been gathered from state and local experts and surveillance and informatics experts. The first being a report that was done in 2013 on the NNDSS, and then a more recent input from a small work group this past year. And then finally, I'll end up with a few of my own final thoughts reflecting on this input that we have received from state and local health departments on surveillance. Next slide. So Dr. Richards has already alluded to the structure of national notifiable disease surveillance in the country, and I think most people on the phone probably are aware of the fact that public health surveillance and public health protection is primarily a role of the state and local health departments. We're really a confederation of agents working for the protection of public health, and we don't have one system throughout the country that is used for collecting data. So this slide basically illustrates the fact that reportable conditions are defined by state law or regulation, and health clinicians and laboratories usually report to the local health department, which then reports to the state. In some places, the reporting is directly to the state for these mandated conditions for reporting. And then those conditions that are decided by the Council of State and Territorial Epidemiologists to be reportable nationally are what we refer to as notifiable conditions, and those conditions then get reported to CDC, assuming that they meet an agreed upon national case definition, which is also usually decided by CSTE in close consultation with CDC. And there are about 100 diseases or so, or conditions that are nationally notifiable. And not all conditions that are reportable to the state are notifiable to CDC. Just a couple of examples. In some states, asbestosis or congenital malformations, for instance, are reportable, but that information is not transferred to CDC across the country for notifiable condition surveillance. Next slide. Also, this slide basically is a very simple slide that reflects information that Dr. Richards also covered a moment ago. But basically, the NNDSS, the National Surveillance System, is really under tremendous change, and the two major forces that have already been alluded to are the capability of handling increased amounts of data by computers, which also increases the speed, and then more recently in history, the revolution in health information exchange. And why this is important, really, especially to all of us, but it affects the state and local health departments tremendously because they often don't have the resources to quickly adapt to technological changes. So we live in an age when the surveillance system that's based on computer and technical expertise is changing rapidly, requires resources that were not needed several decades ago because it was these influences were not existent, and also require a certain speed. The last comment I would make is that these forces are requiring that all of us in surveillance, the state, local, and federal level, agree on standards. We have to do things the same way so that our systems can talk to each other. And so more and more we are forced to and required to set common standards. And I would suggest that the CDC surveillance strategy is being driven by these forces, and a lot of what Dr. Richards spoke about has to do with communication and coming up with common standards and doing things in a productive way in this new age. Next slide. So what I'd like to do is first talk about the 2013 report on the NNDSS from a state and local perspective. This was really part of a larger review of the NNDSS that was funded by CDC's Division of Notifiable Diseases and Healthcare Information starting in 2011. The first phase of the review actually focused exclusively on surveillance processes within CDC. As you know, CDC is made up of innumerable programs and, as Dr. Richards has commented on, a lot of different discrete surveillance systems. So that review, the first phase really dealt with internal CDC issues and not so much with the state and local issues. The second phase, which I'm going to talk about here, deals with the needs and perspectives of state and local health. And what we did, I led the review of this aspect of the study, and we reached out to state and local health departments. On the slide shows 4 different ways we actually got input. We had a pre-conference workshop at the 2012 CSTE annual conference. We also used the annual CSTE surveillance assessment survey in 2012 to gather information that was particularly pertinent to issues that were raised at the pre-conference workshop and that were current. We also convened a 15-member guidance team of state and local surveillance experts, as well as some at the federal level, to provide input and comments. And then lastly, we did in-depth, in-person visits and interviews with 6 state and local health departments to really try to tease out at a workflow level what some of the challenges were that state and local health departments face to try to create a successful surveillance system that feeds into the NNDSS. Next slide. This slide provides a little bit of the landscape of surveillance at the state level, state and local level. It's for 2012. It has changed maybe a little bit, but for the most part, this is still current, and just describes and highlights the fact that states, because they are independent in terms of how they do surveillance, have a number of different types of systems that they use to computer systems to manage the information as it comes in. 17 jurisdictions use custom-built systems that they built themselves. 15 use commercial systems, as you can see itemized on the slide. And then 19 or so used a CDC-developed and supported system, the NEDS-based system. And the findings that will come up in a minute when I review the results suggest that people are very happy with their own system, and most of these systems seem to be functioning very well. Next slide. So the 2013 report had a number of findings, far too many to go over here, so I had to select the ones that seemed to bubble to the top. And I just alluded to the fact that the first thing that was kind of surprising to me was that almost to a person, everybody was very satisfied, or at least fairly well satisfied, with their surveillance systems and computerized surveillance systems that they use, despite the challenges and the fact that there are lots of expenses and difficulties that they face. 3 issues really rose to the top in our survey information. The first was gaps in the public health informatics capability at the state and local level. Everybody agreed that with the increasing use of technology, surveillance and epidemiology staff in public health really need more informatics training and help. The second and third issues were insufficient resources to do what they felt they really needed to do to have an effective surveillance system, or an optimal surveillance system, I should say. And the third was the need for increased coordination among CDC programs, which Dr. Richards has alluded to. This is an important issue for state and locals because if there are over 100 surveillance systems to which states are submitting data, it's very cumbersome to try to keep 100 different systems in progress and collecting data in multiple ways at the same time. It really can streamline things if we can increase coordination among those surveillance systems. Two other points I thought were worth highlighting was a repeated comment that there were unclear reasons for collecting selected CDC variables. And the reason this was important was that when the surveillance officers at the state or local level ask for certain information, whether it be occupation or travel history or detailed vaccination history, if they can't explain to the reporters why they are collecting that information, then it undermines the importance of surveillance to the reporters. So that was a kind of a high point that kept repeating itself. And then lastly, the idea that changes in CDC long-term surveillance plans really challenge state and local planning. So that if CDC changes direction, it often means that systems that are half-built at the state or local level have to change directions too, and time and resources can be lost in that process. Next slide, please. The other thing I wanted to talk about in terms of perspectives from the state and local level is a group that was formed just this year. Actually, Dr. Richards convened what he called the Public Health Surveillance Work Group, and informally we refer to it as the think tank. It was formed in August 2014. It's an informal advisory group to the what's referred to as the STILT, the State, Territorial, Local, and Tribal Subcommittee of the Advisory Committee to the Director of CDC. So while it's an informal group, it does provide a way of getting input to the highest levels of leadership at CDC. The members of the think tank consist of several of the members of the STILT subcommittee itself, as well as others with extensive surveillance or informatics expertise. And again, the goal is primarily to assist CDC to better conduct its work through the lens of state and local agencies. Next slide. So what I'm going to do now is just quickly run through 3 of the recommendations that came out of this work group just in October. These were recommendations presented to the subcommittee. And the first was to formally endorse the surveillance strategy that Dr. Richards has just described, and in addition to encourage CDC to not change or modify the plan for a few years, like in the near future, 2 years, to stay the course. And again, this is to answer the need for states to have a consistent direction so that as they build and modify their systems, it could be consistent with the direction that CDC is going. The committee also made the recommendation that parsimony should be used, particularly around requirements, data standards, and targeting of funding. And I would say that in terms of the targeting of funding, they are not referring to parsimonious funding, decreased funding. They're really talking about parsimony in terms of directing the funding to what can most improve or protect health. Next slide. The second recommendation was to formalize a roadmap process for implementing harmonized data standards. And I've already alluded to this, but the group elaborated on this a bit by saying that we needed to balance flexibility so that states were not too hand-tied to an inflexible or a difficult set of standards, but also have enough prescriptiveness in the standards to make sure that we could all speak together, speak with each other electronically and effectively and efficiently. And then we also made some recommendations about funding and supporting the use of harmonized standards. Next slide. The third area of recommendation included endorsing the development of an electronic surveillance workforce plan. And as you can see on this slide, there were several specific suggestions on ways to do this, with the emphasis on training, especially workforce development in informatics, as well as workforce skills to increase modeling and data handling and analysis and publication of results in a way that the public can most easily grasp and use that information. Next slide. So I will conclude with some final thoughts of my own. The first is, I think it's important as we all face really major challenges with the informatics and technology age we live in, to remain optimistic. We have a very sophisticated national surveillance system, and the state and local health departments are functioning fairly well based on their feedback that I described a minute ago, and in spite of a lot of constraints and a lot of challenges. So I think we have a lot to be pleased about. However, as outlined, there are a lot of challenges, and they're substantial, and they're not easy to address easily. But I think that the answer lies in communication and trying to standardize and harmonize standards across the country as best as possible. And I think we see an increasing alignment of priorities at the federal and state levels, partly as a result of the national surveillance strategy that you just heard about. So I look on this as a real time of opportunity, and I remain very optimistic that I think we're making significant progress. I'm going to conclude here and move right on with our third speaker, Dr. Paula Hume, who is the director of the Division for Health Informatics and Surveillance at CDC. This is the part of CDC that operates the NNDSS and the National Syndromic Surveillance System. So, Dr. Hume?
Great, thanks, Dr. Smith. So today I'm going to give a high-level overview of the NNDSS Modernization Initiative. And as you heard from Dr. Richards, this is one of 4 major initiatives that are in the CDC's new surveillance strategy. Next slide. So the problem that we're trying to solve through this initiative is that the infrastructure supporting the National Notifiable Disease Surveillance System, which processes data on approximately 100 notifiable diseases that are sent from states to CDC, really needs to be strengthened and modernized so it's interoperable and has standardized data and exchange mechanisms. You heard from Dr. Smith the complexity of disease reporting with the increasing use of electronic data exchange and the many different systems that are found in the state and local health departments. So the long-term goal of this initiative, the long-term goal of modernization, is that all the notifiable diseases will be reported to CDC from states using HL7, that's Health Level 7, an international standard for transfer of clinical and administrative data. And this will be done via a message validation and processing system, which I'll say more about. Next slide. So as you heard from Dr. Smith, NNDSS is a collaboration between CDC and state and local public health agencies to collect and report data on about 100 different diseases and conditions that are under continuous nationwide surveillance. And these conditions range from things such as carbon monoxide poisoning to dengue fever. Individual states have laws that mandate what diseases must be reported to health departments from health care. And the list of reportable diseases varies in each state. A subset of these reportable diseases are notifiable and are reported to CDC. Reporting of diseases from states to CDC is voluntary, and reporting guidelines and case definitions are established by CDC and the Council of State and Territorial Epidemiologists. CDC Center for Surveillance, Epidemiology, and Laboratory Services operates the NNDSS program. data are collected from states, provisioned to the disease-specific programs, and published in the Morbidity and Mortality Weekly Report, published on Wonder, which is the CDC website of online databases, and also published in data.gov, a U.S. government open data site. Next slide. There are three major components to the NNDSS Modernization Initiative. The first activity is to develop new message mapping guides for each of the diseases. These are the guides that describe the data elements, the valid values, and the HL7 mapping instructions. It defines how the package of data elements is put into a message. The second area is the development of the message validation and processing system. This is the system, the hardware and software, that enables receiving data, processing, storing, validating, and provisioning the data to the CDC programs. The third component, and a very critical piece of this initiative, is technical assistance to states for implementing the new guides and using MVPS. As you heard from Dr. Smith, there's a real lack of informatics capacity in many states, and there are insufficient resources to reconfigure state-based systems every time new message mapping guides are developed. So an important component of this initiative is to provide technical assistance along with CSTE and the Association of Public Health Laboratories. This will be ongoing for some time to come. Next slide. Currently, data are sent from states using three different formats. Most of the data is coming in what we call NETS files. These are systems that have been around for 20 years or more and are outdated. About 17 states and a handful of territories use the NBS system, and data comes in through a master message. Less than 1% of the data coming in right now is HL7. And as you heard, our goal is eventually to have all of the messages coming in as HL7. Processing for the data, that is provisioning the data to the CDC programs and publishing aggregate data in the MMWR and on Wonder, is currently being done using outdated manual and technical processes that are resulting in data errors and are offering up incomplete data. So this is one of the things that we'll be focusing on. This system includes over 5,000 data elements. So really harmonizing these elements across programs could reduce the number of data elements and reduce reporting burden. And harmonizing is really trying to identify a way for data elements to be captured in the same format. So for example, a particular disease report could ask the question, has this person traveled internationally in the past 3 months? Whereas another report might ask, has this person traveled outside the U.S. in the past 3 months? That's an example of two data elements that are not harmonized. Next slide. This is an example of what the data flow will look like once the system is complete. If you start from the left at the top, data is received from labs, providers, and clinical facilities through many different surveillance systems and into databases at the state level. The data is then integrated using integration engines and other tools. An HL7 message is created and is sent to CDC. Eventually, all of those messages will be HL7. The messages are processed. Data is provisioned to CDC programs to the right, and aggregate data is provisioned to the MMWR, Wonder, and data.gov. One of the key pieces that will make this different than what is currently happening is the message monitoring and reconciliation dashboard you can see at the bottom. This is a data quality tool that will allow the states to look at the data that they send and immediately determine if there are errors or problems in sending the data. Next slide. The modernization of NNDSS includes many stakeholders and collaborators. Obviously, there are the disease-specific programs who are responsible for the data collection or responsible for using the data that is received by CDC. There's the Division of Health Informatics and Surveillance, which operates this surveillance system. Obviously, state and local health departments are critical. This is where the data are captured and used for public health action. There are many public health partners, the Council of State and Territorial Epidemiologists, the Association of Public Health Laboratories, the Association of State and Territorial Health Officials, the National Association of County and City Health Officials, and others. And then, of course, there's healthcare and labs and clinics where the data originates. Next slide. The timeline that was laid out for this initiative was to focus within the first year on creating 6 priority message mapping guides. A generic message mapping guide that includes all of the core data elements and includes all of the essential elements for approximately 20 diseases. So every single disease will use the generic version 2. Many diseases will have additional data elements. The other guides being developed this year are guides for STDs, congenital syphilis, hepatitis, mumps, and pertussis. The second big activity is building and testing the message validation and processing system that will be used to capture, transform, and provision the data. And then importantly, providing technical assistance to 10 states to implement these 6 priority guides. This was our target for 2014. That target has slipped a bit, and it is likely that this work will be completed in 2015. Long-term activities, 2 to 5 years off, include completing the rest of the message mapping guides. As I stated at the beginning, there are approximately 100 different conditions that are part of this system. Enhancing the message validation and processing system. There's an interest in eventually putting this system and application in a cloud environment, and developing other service and tools that could be useful for the data, such as analysis and visualization tools. We will continue to ensure the standards and harmonization across diseases, and a big goal for this activity is to eventually retire NETS, which I described as the outdated system we are currently using for data exchange and processing. Next slide. This is the performance metric we have established for this initiative. If you look at 2017, the goal is that by 2017, approximately 85% of the messages will be coming into CDC as HL7 messages. Currently, in 2014, less than 1% of the messages are HL7. Next slide. In terms of our progress, 4 message mapping guides have been vetted and are ready for testing. Those include the generic version 2, hepatitis, STDs, and congenital syphilis, and mumps and pertussis are nearly complete. When I say vetting, we have a website where the guides are posted in all their different variations that allow state, locals, and others to provide input along the way. Another accomplishment has been best practice recommendations for unknown and missing values in the messages. This seems like it would be a fairly simple decision, but it was very complex, looking at the needs of the many CDC programs involved in terms of how they need their unknown and missing values coded. We're also, as I mentioned, working with CSDE and APHL on developing a technical assistance plan. They've completed a capacity assessment and readiness assessment within 14 states, 10 of which will be included in the pilot. Work has already begun in Michigan in early October, and starting tomorrow they will begin user acceptance testing. And lastly, an HL7 message structure validation work group has been formed to look at the possibility of developing 2 new generic type messages, one that focuses on laboratory data and another on vaccination data. These are data elements that many of the diseases use and could help harmonize the process. Next slide. Our next steps are to continue to develop the message validation and processing system, to conduct an alternative analyses that may lead to some changes with that system. We also plan to begin a more robust data element standardization and harmonization process. We'll be looking at all of the data elements that have been approved by the Office of Management and Budget For the Paperwork Reduction Act, all of the data elements that are collected in these systems must be approved by OMB. We will identify data elements that are likely ripe for harmonization. I gave you an example of travel earlier. We will begin developing the lab and vaccine core message mapping guides. We will start on the next set of diseases, and we will create a repository of these harmonized data elements which may be useful for other programs and surveillance systems. And of course, we will continue to provide technical assistance to states, and this will be an ongoing process well into the rollout of the new modernized NNDSS. So to wrap up, the streamline and standardized data exchange should increase the consistency, timeliness, and quality of the data coming into this surveillance system. More efficient data exchange between healthcare and public health is critical as we move forward with harnessing the value and the data coming out of the electronic health records and really ensuring that this data is being used to promote population health. Better data quality will increase its value for monitoring disease activity, assess the effectiveness of prevention programs, and learning about factors that cause disease. Next slide. These are contacts of our key individuals that are working on the NNDSS modernization initiative, the program manager, the lead for the message mapping guide, lead for the message validation and processing system, and lead for the technical assistance. Thank you.
Thank you very much, Dr. Hume. That was great. And thanks to the other two speakers. We'll now take questions from our audience. You may type your question in for any of the authors. You can type your question into the chat or question box in the right-hand corner of your screen. You can open the box by pressing the two arrows. To help us with the Q&A, I'd like to introduce Erin Williams from ASPPH. Erin?
Thank you, Dr. Shaw. We have our first question for the panel. In your list of CDC surveillance priorities, you have described activities that relate primarily to systems that depend heavily on state electronic laboratory reporting capacities and automated death reporting. Can you say more about how your efforts to address these priorities will enhance surveillance capacities throughout the CDC? I believe this was posed to Dr. Richards.
Thank you for the question. The initiatives around electronic laboratory reporting and electronic mortality reporting are going to help us advance more integrated surveillance in at least two ways. One, mortality reporting and laboratory reporting are data flows that we use in other types of surveillance. So for example, the electronic laboratory reporting is useful and actually critical for our national notifiable diseases. So if we improve the laboratory reporting and really turn that into an electronic reporting system, it will support our other efforts on notifiable disease system modernization. On electronic mortality reporting, there are other systems at CDC that collect mortality data. One good example is the annual influenza mortality system, the 122 cities death or mortality system, where data is collected from over 100 cities across the country each flu season to know how many people are dying with flu or of flu. We found in our early work with the electronic mortality reporting using vital statistics that we get comparable data through that system and can probably replace or discontinue the 122 cities flu mortality, a very specific type of mortality system, in the next couple of years using the more platform-based vital statistics system. So those are two examples where these activities will support our other surveillance activities.
Great, thank you very much. Dr. Hume, a question for you. What does CDC do with the case notification data reported by the state?
Sure, I'd be happy to take that. Well, the data that comes in to CDC, as I mentioned, is provisioned to the disease-specific programs, and they use that data to monitor the occurrence of diseases in the population, to identify populations and geographic areas that might be at high risk. They also use the data to plan and evaluate prevention and control programs, to allocate resources, and really to look at the effectiveness of what CDC is doing from the national perspective. And then certainly to collaborate and work closely with state and locals to address public health problems at that level as well.
Great, thank you. How can state and local surveillance staff learn more about and provide input into national surveillance issues? Dr. Smith, I believe this one's for you.
Yes, thanks for the question. This is an important question because I think that state and local surveillance staff have a big, important role and a lot to offer for input into issues around national surveillance. Especially for people that may be entering the public health workforce and fairly new to surveillance, I would encourage them to check out several websites. Obviously, the Centers for Disease Control website has information not only on the surveillance system, but also on some of their training programs. The Council of State and Territorial Epidemiologists, CSTE.org website, has a lot of information and a very active committee structure to which anybody is invited to sit in. These are national conference calls, very informal conference calls for surveillance. They have 3 or 4 different subcommittees that work on such issues as the informatics as it relates to surveillance, surveillance policy issues, electronic laboratory and disease reporting issues. So I would really encourage people to check that website out and to join any of these national phone calls to learn about these issues, as well as, most importantly, to provide their insight and provide input into issues that are current. And then the last source that I would mention is NACCHO, the National Association of City and County Health Officers. NACCHO.org is a very good source of information about surveillance and has also some committee structure that provides an opportunity for sharing with colleagues and for providing input. You do not have to be a county health officer to be a member. It's open to the public, and they have a public health and informatics webpage that I think would provide a lot of input, provide a lot of information, and allow one to get involved with these issues. So I would encourage our listeners to make use of any or all of these resources to get involved.
Great, thank you. Here's one it looks like has to do with what Dr. Richards is discussing. Regarding your observation that there are greater than 100 surveillance systems at CDC, what is your office doing to address the concerns that arise from this multiplicity of systems?
Thanks for that question. Yes, thanks for that question. As we've described with some of the initiatives this afternoon, our initiatives are really aimed at improving data flows and data platforms that can be used for a multiplicity of surveillance purposes. The example that I gave earlier about a single flu mortality system having the potential to be replaced by a system using vital statistics that can provide mortality data for a wide range of different diseases and conditions. So that's one thing that we're doing. The second thing that we're doing is we're harnessing the innovation that's occurring both in the agency and in state and local health departments around informatics. Many of these innovations are siloed projects that are really great, but people don't learn how to implement necessarily the successes or learn from the failures from those projects and more systematically and in a more integrated way use those innovations across the various surveillance systems we have. So that's a second activity. The third activity that Dr. Hume talked about was standards. As you see with just the example of the Notifiable disease system that has 5,000 data elements, there are different ways that our programs and our state and local health departments are asking questions about what are essentially the same concepts around fever or around travel. And so harmonizing those standards, we think, will create more efficient and more integrated data collection and surveillance activities. So those are three concrete examples of things that we're doing.
Great. Dr. Smith, why is staying the course on surveillance strategies so important?
Yes, thank you for this important question. This staying the course is the phrase that came out of the advisory, the small think tank work group a couple of months ago, and was directed basically at the federal level at CDC and probably Washington, where the funding comes, a large part of the funding comes for national surveillance. I think we all, any of us who have been in public health for a while, understand that that we work and live in a political environment. That is, the leadership in Washington changes every few years, and therefore the priorities in public health, including surveillance, may change, not to mention, of course, all the changes that are going on in terms of the technical and informatics substructure on which we're built. So this creates a problem for surveillance that depends on expensive systems that often take several years to build and to refine. If the direction in which surveillance is being led from the federal level changes frequently, then the states and local health departments never feel that they actually catch up and end up spending a lot of time and or resources doing things that that don't ever get to completion and productive use. So that's what prompted the phrase "staying the course," and I think that the trick about this is, of course, no one controls the political process in public health, and we all understand that sometimes a course is set that has to be changed, so that this is not an absolute. But I think the reason that the committee came up with staying the course was that it was a reminder to all of us that when you make a change in a surveillance strategy, be very attentive to the ramifications of it, and remember that every change has a cost, and that it doesn't mean that you can't change your strategy or change your direction, but to do it with wisdom and insight into what direction you want to lead. So that was I think the message from the think tank that prompted that comment. Thanks for the question, though.
Thank you, Dr. Smith. I think we have time for one more question. Why are message mapping guides needed to send disease-specific data to the CDC? Dr. Hume, do you want to take that one?
Sure, I'd be happy to. I really see the message mapping guides as the key to standardization. These are the instruction manuals that tell you how you take a data element and package it into a message. And the fact that the Division for Health Informatics and Surveillance at CDC is working with all of the subject matter experts in all of the programs across the agency that participate in NNDSS, this allows us to work with them, and to the extent we can, really try to standardize the data collection across many different categories of data. So the message mapping guide is really a key element. It's also the instruction manual for the state and local health departments when they're taking their data and reporting it to CDC. So it's a core component of this modernization initiative. We're looking at ways to speed up and make the process of developing these guides more efficient, but they are the key tool that will be used for many years to come to describe what we're going to be collecting in this system.
Great, and I'm sorry, but that's going to be all the time we have for questions, but any unanswered questions submitted will be addressed by our panelists and posted on the PHR website with the webinar archive and presentation. Dr. Shaw?
Thank you, Erin, and thank you to our three great speakers, Chesley Richards, Perry Smith, and Paula Hume. It was great. Great talks. Thank you. And a special thank you to Erin Williams for managing this webcast on behalf of Public Health Reports and the Association of Schools and Programs of Public Health. This marks the end of the Meet the Author webinar. Watch the Public Health Reports website for upcoming Meet the Author webinars. Thank you, everybody, and good afternoon.